Okay, good. Now we are going to just hold lots of the time. Exactly, make the larynx correct and try the tip of the blade just behind the epiglottis.
What you told me, when you to go in that way, then put the balance. See, this is the group work.
Pressure on the teeth.
On the right side. And elevating it. Yes.
جماعة الجروب الكبير يقول شنو قاعدة جماعة السابي روتيشن كان دواية وان كان فمجال جروب تاسك كذا أو دواية استابشن دواية سنيانة كتانا فوتي دواية وزن
شو سيناريو
تازه آن دست بکن
آخر بويش تانا دست نتشين أو ده كردني دواية ورا واحد ورا برايفت لسنة بيالن برايفت خاص تريشي وايتها بوانا منوت وخمنا
دعای به تو به ما شاء الله.
Now Dr. Firas will talk about basic airway, advanced airway and definitive airway, how you are going to predict the risk of the هذا هيك يطلع لو اكو زين شغله هذا just for insertion not for it تمام okay now what are the signs of the airway obstruction? What are the signs of airway obstruction?
When we look, there is no chest movement.
No, I'm talking about the airway tract, not breathing.
Agonal breathing.
No.
There could be partial obstruction.
Yes. What are the features of the stridor, gurgling,
Noisy chest.
snoring? Okay. Or if there is lip swelling, tongue swelling, or any neck swelling. Okay.
If there is complete obstruction,
And
there is no.
the other scenario is unconscious patient. Every unconscious patient, the airway is at risk. So how we are going to open the airway?
Head tilt, chin lift.
Okay, good, excellent. And if suspected cervical spine injury, you are going to use jaw thrust. Good. And if there is any foreign body secretion, blood, vomiting inside mouth, you are going to evacuate by. Okay, how you are going to do suction? Just show me. Do head tilt and chin lift, and use the suction and tell me. Good. This is jaw thrust and head tilt and chin lift. بالبداية عدلها شوية. Neutral position. إيه. هسه سوي لي head tilt and chin lift. This is jaw thrust. Okay. Head tilt, just tilting the head and lifting the chin.
Okay.
Tilting the head and lifting the chin. Okay. Now, how you are going to keep this maneuver? There is a device. You have two devices called basic airway adjuncts. One of them is this one, called oropharyngeal airway, and the other one is the tube in front of you, which is called nasopharyngeal airway. Oropharyngeal airway is fit for any patient if there is no gag reflex. When you are going to evacuate the mouth of the patient, if there is gag reflex, there is no place to put oropharyngeal airway. If there is no gag reflex, you are putting the oropharyngeal airway. And now how you are going to measure it? The oropharyngeal airway?
Incisor teeth
To the angle of the mouth. Excellent. Good. Now extract this and show me how you are going to measure it and insert it.
So this is the incisor, this is the angle.
Good. And show us how you are going to insert it.
I insert it
Upside down between hard and soft palate and
then
360 degrees. Now the airway is maintained, not protected. Okay. This is instead of your maneuver. Okay. Now the airway is still at risk. So what is the definitive procedure? Any patient tolerate oropharyngeal air definitely need intubation. What are the devices you need for intubation?
Laryngoscope.
Good. Show us how you are going to use it, handle it, and tell us the parts of the laryngoscope.
This is the blade.
Good.
This is the handle. Actually,
Good.
this should detach.
Okay, good. Excellent. And there is a light working valid, that's it. And this is the way how you are going to handle it, and tell them, Dr. Firas, how they are do intubation. Good.
Sorry, doctor, can you repeat the maneuver of jaw thrust, how it's done?
I must show you. Okay? You are putting the middle fingers of your both hands behind the angle of the mandible, and subtly you are going to do like that, this maneuver, okay? Just fix this for me, please. Fix this for me. You are going to like that. Protrude the lower jaw upward to the ceiling. This is jaw thrust from the angle of the mouth. Okay? This is jaw thrust, and you are looking for secretion, vomiting, bleeding, blood, fractured teeth, everything. And you are going to, this is rigid. Where is it? You have a rigid, rigid device for suction. You have flexible one. If there is no gag reflex, mean the airway is at risk. This patient cannot swallow, cannot expel any foreign body. Okay, so you are going to maintain the airway by oropharyngeal airway. If the patient not fit in oropharyngeal airway, you use
You know the anatomy? You know the anatomy?
You are supposed to know.
So, these are you. So this is the tongue. Okay. And this is the epiglottis. After the tongue, this is the base of tongue. This is the epiglottis. Where we should put the laryngoscope, the blade, should be above the epiglottis, not below. Why not below?
Below esophagus.
No, not below the epiglottis, I mean.
Yes.
We should go to this space between the tongue and the epiglottis. We put the blade here and then move up. Why? In order to see
the vocal cord.
To see the vocal cord. That's the vocal cord. It's like 8 in Arabic, okay? That's the vocal cord. If you see the vocal cord, you can go put the tube inside. But if you don't see the vocal cord, don't try to put it blindly, because definitely you will go to the esophagus. Esophagus is very closer down than the vocal cord. Important things, we should put the blade above the epiglottis, because if we go below the epiglottis, we will do injury to it. It will be swelled rapidly. You cannot imagine, and you cannot do the second try of intubation. Okay, because we always think about second, maybe third. Even we see vocal cords, sometimes that you go to the esophagus and even test it, it's not in a place. Okay, so we need to think about the second try. So this is you know this anatomy. Goes just above the epiglottis. How to put the laryngoscope? 45 degrees. Up and forward. Up and forward. So 45 degrees like that. Not straight like that. This is on see where the pressure is on the teeth.
Upper teeth and you will
Yes.
block.
So patient came to to the theater with appendectomy. For appendectomy, they go out.
Habibi.
Patient enter the theater for appendectomy.
And they go out teethless.
with 2 teeth and appendix.
Right. This is one of the pitfalls of the intubation.
Yes.
You know why all guidelines is go with the basic, non-invasive, less traumatic, less harmful. Even the 2021 just satisfied by putting these devices, advice airway. This is called iGel, this is called extraglottic device, laryngeal mask. It is simply you are holding like a pen and this will settle on the pharynx, okay? This should be facing the pharynx and this temporary will occlude the esophagus, but this is not 100%. Even sometimes this will enhance vomiting in aspiration, because the patient cannot expel it out.
But it's much easier.
More
It's a blind
easier for
technique.
ventilation.
Blind technique
Yes,
for
yes.
ventilation, yes.
Better than the oropharyngeal airway.
Yes.
Mm.
Okay, so simply these are what you need. Nasal, oral airway, nasopharyngeal airway, tube. Important thing is to oxygenate the patient. Don't try too much to put it intubation, to put that into the tube. Okay?
So ideally it should be within
be-
1 minute, 2 minutes, or less?
This patient is like you. Sometimes they advise you to hold your breath.
Yes. Yes.
Okay? When you need oxygen, the patient needs oxygen. So if you cannot succeed.
So hold your breath, let us see how much you can
Yeah,
withstand.
1 minute.
Not more than
Seconds.
1 minute. You are super in the
You cannot,
You may be
succeed
one
to
of
put
the
intubations.
senior trainers.
Just ventilate the patients with Ambu-Bag, then try again later. Okay? So this is important. Don't try too much because the patient will die from hypoxia, not from the injury. Okay, so that way.
Doctor, the procedure for the iGel, please. Can you?
It's a blind technique.
The only difference between the laryngeal mask airway and the iGel is this inflatable and this is not inflatable. So already there is, let's say, bulging. While the laryngeal mask airway, there is a balloon should be inflated.
Simply, it's just to ventilate. You will not see it too much in the
And there is a
emergency.
side orifice for the suction.
So
And at the distal end there is a tip.
how
Yes.
much we
How
go
to choose
in?
the size of this?
How much you going?
Yeah.
But the same.
How much we go in and how we know it's really in the right place.
When you are going to ventilate, you should find the elevation of the chest. Because this will fit for the Ambu-Bag, not for the mask, When you use laryngeal mask airway or iGel, mean the patient in respiratory arrest. What is the definition of respiratory arrest?
Most
Happening
Unable-
patient,
Unable to ventilate.
agonal breathing, respiratory rate less than normal HNA. If less than 10, this is regarded, according to the guideline, any patient respiratory rate less than 10, this is regardless of useless respiration. You need ventilate, okay? Same for the pediatric age group, when become unresponsive, collapse, any floppy, shocked child, pulse rate is 50, this regarded as cardiac arrest.
Yes.
So in the advanced pediatric life support, you are not dependent on the pulse. In the adult, you are dependent on the low glycemic field and check the pulse. We say, please check the pulse. Reliable. While in the pediatric age group, pulse is not reliable. Even 50, even 60 arrest. Okay? So you say for the pediatric age group, is there any signs of life? No. This is arrest. Activate cardiac arrest team, do ambobagging, do good quality chest compression, and maintain airway, open airway, clean airway, and do ambobagging. Okay?
Okay.
How much you are going to do ambobagging? I mean bag valve mask inflation. Every how much?
Every 2 seconds.
Every 5 seconds to 6 seconds in adult.
10 times.
In
a minute.
Because we have 12 rate.
Yeah.
Respiratory normally 12. In order to achieve the 12 breaths per minute, you are going to inflate every 5-6 minutes. Well, for intubation, if you are going to do pre-oxygenate the patient, you should give full amount of the oxygenation continuously. Before intubation, why you should give oxygenation before intubation?
To buy time. To buy time.
You want to fill all alveoli, all red blood cells, even all the myotomes with oxygen in case if you fail intubation, the patient half reserved for the next 5 to 10 minutes. Good oxygenation makes your patient half preserve of oxygen for the next 5 to 10 minutes.
So how much should this pre-oxygenation continue?
15
2,
liters.
3, 5. Sometimes some anesthetists prefer 5 minutes. Better to ask this question to Dr. Aziz. Okay, he's an anesthesiologist also, Dr. Anesthesiologist.
And how much oxygen you should give?
150 liters per minute.
Okay.
Every critical ill patient, every arrested patient, because one of the arrests is hypoxia, so you should give 100% oxygen, okay?
Other important points to notice that you should go from the right to left.
Collect the
Move
tank.
it right to push the tank, and this group to put the tank in this group and move it away from your vision. Okay? To make it easier to put you. So this is the way. See the epiglottis in front of me now. I see the vocal cord now. You can simply move. Sneak outside lubricant. Okay. To put it where? In the vocal cord, between the vocal cord. Okay? After that, how we know we are in position? We should,
Sculpted the chest.
yeah, but we should inflate this first,
To fix.
then push by Al-Mubarak air inside and see bilateral to check it by stethoscope. Okay, if it's equal or not. Sometimes we are in
the
here,
one bronchus.
yes, but it slips to one bronchus. So what we do in that case?
We will pull it
Just
back.
move it back
Okay.
a bit, then recheck. Okay? Don't forget to deflate and inflate.
Yes, exactly.
Okay? So I think most of you did this before, but then we need to do the yes.
Okay. So I have a question about the selecting the size of the endotracheal
Yeah.
tube.
How we know this is the proper size for the patient? There is an equation. It take time. So roughly speaking, the patient little finger,
Okay.
just put it with it. For example, this is small for my size,
Yes.
but this is fit for his size. Okay, it's the same size, little finger.
At which point we compare it?
It's the
It's
same
the same.
diameter.
Same. Just-
Okay, I got it.
Okay, just see. This is very small for me.
Yeah, exactly.
Maybe you?
Is it regular? Any
Yeah.
accurate
this-
enough?
Yeah. It's acceptable. And you use it because we need time. We don't have time to waste. So yeah, this is the proper size for her.
What
for
about
her.
the length that we have to put inside the larynx?
You should decide because you are the one who holds the tube. Whenever you go to beyond the vocal cords, it's like 1 to 2 cm. Then
It's enough.
yeah, then exactly. This should go. The bottom should go beyond the vocal cord. Okay, the bottom. It's not should not stay in between the vocal cord and you inflate it because it will damage it. Okay. So the size that we say about the size, how we know this proper size?
Yes.
I think you
we
did
check.
everything.
Yes.
We check from the incisors to
The
the
proper size, yes.
Touch,
We calculate the distance between the incisors and the angle of the mouth.
Mm-hmm.
If this is longer, I think
You think this is longer?
it gets in front of the teeth.
Okay.
that should be okay.
It should be okay.
Simply from the angle of the mouth the other way to the loop of ear. Okay.
Okay.
So if you go that way,
It's
this will be okay. That's the same size. If you see this from the angle of the mouth to the loop, so this is small. Can you use a small size? If you don't have it, this is the only airway, oral airway you have. You can put it.
If it's the only
The only one,
Yes.
Why not?
You should put it.
Yeah.
No.
If it was
No.
It was the only one.
Yes. I tell you what. If it's a small size, what we will do, we will push the tank, we will push the base of tank, and we will close the airway. So you'll add further harm to the patient.
And what
Back
we will
valve
do?
mask.
What you will do? No.
Back valve must be.
If we have the larger one, can we put it?
Yes.
Larger one.
I think no.
Why?
Because the
Problematic to the
thing
airway.
that we
It
need
brings
is to save the position
gagging.
of the tongue to not go
We
to
need
the,
to just protect
to
it from
protect the tongue. So what
which is simply achieved by jaw thrust. Simply achieved by jaw thrust. So if I don't have the proper size airway, don't go with the wrong size.
So nothing.
Even
nor the larger.
if
nor
it's
the-
smaller, we will push the base of tongue and we close the airway. If it's larger, we will close the airway by making injury inside to the vocal cord and epiglottis.
So if it
Okay.
wasn't available, we will step back to back valve mask ventilation.
Exactly. Ambu-back and jaw thrust. Okay?
Okay.
Or head tilt chin lift if you are alone, or if the patient his cardiac is still functioning and or the breathing is okay, we want to protect it, just simply put him on recovery position, as I told you in the lectures, just to protect the airway. Okay? From the base of tongue only, or the vomiting or foreign bodies or these things. Yes, yes.
So we've got.
all of you can try.
So we've got.
You should try.
No, they can not can.
So we put it
Yes.
in the opposite direction.
Okay.
Go
Till we
inside.
reach to the soft palate, then
Then we rotate it 360 degrees.
Believe me, this is life-saving measure. Don't estimate basic airway. This is more important than the definitive airway. Now the definitive airway carry a very high mortality, for your note. Even there is special algorithm called post-intubation cardiac arrest.
Okay.
Post-intubation hypotension.
just palate.
Very hazardous
Okay,
procedure.
Let's.
So if you open the mouth, clean the mouth, maintain the mouth by this basic adjuncts, all that you need, believe me. And always there should be valid working suction machine beside you. And don't worry, if there is anything for vomiting, you can turn the patient to the left.
After measure,
Oh,
so it's probably okay. So like this.
How deep should we suction?
Like this.
You can start from the lateral of the mouth, gently, smoothly, rotational,
And that's it.
until you reach the base, okay? Slightly encroach to the base of the tongue to see if the gag reflex. If the gag reflex, you should use the rope. There is no such like that. Our country used to do like that, like rolling
Just
twisting.
go.
This is not suction, this is torture.
Moving upwards.
If there is no gag reflex, you can dip more deep. In that case, clean all the pharyngeal cavity from any secretion, bleeding, foreign body,
Okay.
vomit,
You need to
blood,
move
and
the-
put the oropharyngeal area.
Okay.
If you cannot put it, put nasopharyngeal area, it is available.
Doctor,
If you cannot put it, just hold, ask one of your colleagues to hold jaw thrust and ambubagi, ventilating, yes.
if the case had basal skull fracture, what shall we decide to choose between these?
Could be on the
And glycocomascular
Yes.
intubation,
Sign of basal skull
intubation,
fracture.
intubation.
Like this?
Initial measures as.
Yes, initial measures, guys. The initial measures, basic airway, and these procedures for the traumatic, surgical, and medical. Okay, what are medical problems for the airway obstruction? Medical problem, laryngeal edema,
Medical.
medical, epiglottitis, upper yes, sore throat, and the most common one, the most common major life-saving, life-threatening.
Anaphylaxis?
Yes, it's anaphylaxis.
soft. You reach to the soft palate.
And whenever there is anaphylaxis, put in your mind, if the patient airway become compromised, usually there will be difficult intubation. Usually.
So should not have
Edema, swelling, deformity of the anatomy. So you should have a backup of the difficult airway trolley, which contains surgical airway instruments. Tracheostomy or cricothyroidotomy? Is that clear?
Not really. Jaw thrust,
Good. Jaw thrust is very important procedure. I like it, to be honest. Even in the medical condition, usually I use jaw thrust. Later when we face a case young age, suddenly become seizing, fitting in front of others and fall on the ground. Just we could do it for it, open, turn to the left side, open it by jaw thrust, and that's all. The patient ate the fit without even, we couldn't reach the, giving the muscle diazepam or lorazepam.
So regarding the jaw thrust with the ambo bagging, if we couldn't find the one that you talk about,
Yes.
if you couldn't find
Yes,
the mouthpiece, so I will ask one of my colleagues to hold the jaw thrust, and you give the ambo bag.
Or you are doing it.
Or what
Now
about
just look to my hand, Jamaat.
What
Just
about
look
that?
to the hand. When you use this one, you should have a correct mask. Okay, this is called bag valve. There is a valve here. Okay, and this is a mask. The holding of the mask will be like that, C and E. Okay, either you are alone, you are going to like that. Okay, like that. The apex of the triangle on the bridge of the mouth. The base will be just encroaching the angle of the mouth, and it should not be on the eye. Okay, C and E. C on the mask, and E you are going to holding the mandible. If you are two person, you are going to handle the back to your colleague, and by manual
I'm going to
going to
ventilate.
use C and E. This is more tight, more fixed, and less air leak. Okay. All of you should know how you are handle the C and E and fix the area. Okay.
So I think most of the junior doctors and the staff, they don't know how
Okay,
to
we-
hold it.
This is the way of
Yeah, I
learning. These courses and events are obligatory for all health providers, including the consultant doctors within high rank. Every 2 years, they should renew their certificate. Otherwise,
Make a project
they should answer some question by nature.
if we are two persons, so this one is for jaw thrust,
Now,
jaw thrust.
when you talk about the ABCD, when we are talking about the ABCD, all will be together. Maintaining airway, breathing, and circulation. For circulation, usual classic way to access the vein is through the cannula. If you fail 2-3 times, the second alternative is
More central veins.
intraosseous. It is intraosseous, okay?
Yeah.
According to the guideline, even in the adult one,
This thing.
the adult one, if you cannot use 3 times the intravenous, you are going to use
No, it was sorry.
What's this?
This is for you for ventilation, C
Ah,
and D. You do for C and D.
You want to get
For
rid
C
from
and D,
it.
and I will make a laryngoscopy here.
Now let us
Intubation.
show you how you are going to do ambo bagging. Okay, you are going to open the mouth, clean the mouth, and put in oropharyngeal airway, and you are going to hold the mask like that, C and E. You are going to hold the angle like that. Okay, and you are going to do
Chill.
inflation. Okay, inflation. Okay, if you are 2 person to rescue, you'll ask your colleague to ventilate ambo bagging, and you are going to use both your hands. This is make more optimization of the ventilation and oxygenation. Where you put the probe of the oxygen here? It is here. Okay, this is for inflation of the mask, not for the oxygenation. Okay. Everyone, I'm going to ask you in the examination today how you are going to do bag valve
Okay.
ventilation.
So
Okay.
You do this, all of you do it with Dr. Sadeek, and when you're finished, come to do intubation here.
I like it. Okay. حضرتك تقول لي the speaking. Now you are going to open, clean, maintain, and ventilate. Open, clean, maintain, and ventilate. Okay. You should verbalize to me. Open, clean, maintain, and ventilate.
Go.
I didn't hear you.
Open, clean. Just give me all of them.
Okay, just verbalize to me.
Okay, maintain
And
ventilate.
show me how you are going to do it.
Yeah, I'll see the
Ventilate.
process.
C, E,
Okay, just try make C half of the mask, C of the half, the one side of the mask. It is not a C like that, okay? C half of the other side of the mask. If you are left hand or right hand, like that, okay? The C will be on the sides of the mask.
Yeah.
On the sides, not on the center, okay? Show me again.
Can you try and flip? No, they have it's fine.
C here, and this three finger you are going to hold. You are going to control the mouth of the patient by your non-dominant hand, while the other dominant hand, and the ventilation will be not full ventilation. It is half ventilation. Should be within 1 second. Half ventilation within 1 second. You saw paramedics doing like that.
That shouldn't be more
This
forceful.
is dangerous because you are going to produce hyperventilation, lead to high respiratory alkalosis.
I do see.
You are going to wash CO2 and there will be hypocapnia. Hypocapnia lead to what? Vasoconstriction and respiratory alkalosis.
This is metabolic, but sometimes physically bully rupture and then inducing pneumothorax.
Right.
Yeah?
Yeah, right. But this is one of the... Sure. That's why sometimes you are going to use also orotracheal, orogastric tube to decompress the throat. Okay, meanwhile, let me discuss about والله بأهمية بيك
The case that tonic-clonic seizure, French hysteria. How can we...
left lateral jaw thrust, okay? If you have buccal midazolam, use buccal midazolam 5 milligram. If you don't have buccal midazolam, you can use 5 milligram diazepam rectally, okay? Until you are going to have intravenous access. If there is 2-3 times fail intravenous access, you are going to use intraosseous data. We are going to talk about it.
What about
If you cannot put it, you will ask your colleague to do burp. Burp means back pressure upward to the right. Okay? In order to visualize.
Sometimes placing the
Like
trigger
that.
like that.
Okay, and I'm going to hold like that. It is a difficult. I cannot see the vocal cords. So you are going to ask your colleague or by yourself, back upward to the right pressure until you are going to visualize the vocal cord. Okay?
No.
Even if you cannot visualize it, you can use stylate. The stylate is a rigid tube, will be overriding inside the orotracheal tube or endotracheal tube and put it inside the trachea, and when the tip lodged on the carina, you are going to withdraw the stylate. There is a tube called bougie. It is bougie like this, something like that. It will similar like that, more thinner. This bougie contains an angulated end. You are going to introduce bougie to the trachea, and you are going to manipulate it. You will feel the rings of the trachea through this bougie, and you are going to override the tube over the bougie and extract the bougie. And how you are going to confirm your tube inside the trachea?
Then is either a
Ventilate
stethoscope.
and the apex of the lung.
Oxygen will be fine, okay?
Bilateral
Chest
expansion.
elevation will be fine. Bilateral, and the most confirmation one is excellent. Entitled CO2. What is the normal entitled CO2?
I don't have an idea.
Well, it's up to 40 mmHg. If you reach 35 mmHg, this quite mean the patient have good perfusion. And this is one of the clue to see your patient return of spontaneous circulation. If the patient got LMA and there is entitled CO2 on LMA, and you see on the graph there is hitting suddenly upstroking or rising of the let us say graph of the CO2, mean your patient return of spontaneous circulation, of one of the return of spontaneous circulation, and after that you are going to do intubate. Not necessary to do intubation throughout the CPR. You are just satisfied by doing basic life support. The maximum one is put in LMA. Why? Less complication, less mobility, less mortality, more easy, and you are not going to wasting of the time. When you are going to do intubation in the cardiac arrest, in which time? If there is
The patient
if
came
there
back.
is chest compression in progress, continue, you cannot do intubation. So you are going to intubate when they are checking the rhythm. After 2 minutes, when they are checking the rhythm, meanwhile the intubation should be like that. And what is the maximum amount of the checking of the rhythm in order to minimize interruption? 10 seconds maximum.
10 seconds.
And it is sometimes impossible to do intubation. That's why they satisfy by putting LMA. The intubation, when the patient returns of spontaneous circulation, you are going to protect the airway by definitive intubation. When the patient gets spontaneous, the trend that we are doing in our emergency department, please call anesthesiologist during intubation. This is beyond the algorithm. According to the evidence base 2021, there is no any change in survival rate of the patient doing good chest compression with intubation or without intubation. This is evidence based, according to their literature and researches.
Effective ambobagging. Support the one intubation and delay intubation to ambobag good.
Yes. All that you, yes, but yes, excellent. But the problem, if you cannot ventilate, the worst scenario, if there is obstruction of the upper airway, and when you are going to inflate in the ambobag, there is resistance, there is persistent hypotension, desaturation, means there is upper airway obstruction. Now the definitive procedure for this is called surgical airway. Okay? It is cricothyroidotomy. Cricothyroidotomy, better, less invasive. Cricothyroidotomy because you have just skin subcutaneous tissue and the minute veins, and you have cricothyroid membrane. While there you have thyroid, you have tracheal vein.
And they don't say it's have more complication after that?
Tracheostomy has more complications.
Tracheostomy is somehow invasive.
But the trick is there, good, excellent. The trick حزكيتو دست سيرم كالجماعة ده أم أشهر سيا بلعم أم سيا بعشرة أنا قباتك دواية ماي سيجا ميزكشن بيو قباتك نقدر شنادي هو بو pediatric زور باشا يعني دواعي كان أم مشكلة كتشيا أم maintenance وشتانينية جماعة the proper way to get intravenous access is through antecubital line to put 2 white short cannula, and you are going to take in blood for sampling, for blood group, for fluid, for drugs, for everything. If you have failed 2, maximum 3 times, the alternative method of choice is through the just below the tibia, okay, in the anteromedial part, 2 finger between tibial tuberosity, you are going to select. This is for the, let us say, middle-aged or less towed, 40 kilo, 50 kilo. This is for more obese and more soft tissue, okay? And this is for child, pediatric age group up to 40 gram. Good. Now this is 2 sample. You are going to fix this hole, which is fitted for this drill. You are going to just make like that. Let us choose which type. This is supracondylar. If there is no place, what is the contraindication of this one? If there is any inflammation, cellulitis, abscess here, or there is same fracture, okay?
Bleeding tendency.
Or if there is, it is relative. It is relative because this is type. Excellent. So let us choose this area. Simply, you are going to pierce like that, okay? I'm a زهر والله النبي عبروا على الله
وأفضل بآخر بيشتري كراب.
هنا قبل شنو على البين. جماعة the ideal way is the anteromedial part of the upper tibia, just 2 fingers or 2 centimeters below the tibial tuberosity. You are going to pierce the soft tissue, okay? And hold like that. بقرا يلا. دي بابرا
كانت عندنا جميلة.
مع شحنتي أنا مع زين.
دكتور عندنا جميلة وعندنا جميلة إسكات.
هو شحنتي أنا. أنا كافي. خلاص احنا جماعة دائما ما دريني باشا
بس هنا
الجامعة طبعا لكم كانوا لا هني تيايا
fingers below.
أو ليه بستعمل سورسكي نازاين شيء فرمانا مشتكى اللي ويهاتوا بريناري نكنا والله نازاين شيء ما كاتوش يشتكين جماعة this is ready for use you can use everything that you'll consider this intravenous okay you can aspirate blood for every test but labeling the tube this is from the IO can give blood fluid everything you can give it one more way بله and اگر patient can conscious when not need local anesthesia if conscious you should give local anesthesia lidocaine okay good
تقدر أو يعني
انجا استا اما 3 ويكا حسكي بامسري لي بستين بويرا عملية بستين
أو يعني
3 ويكا بويرا طبعا امام نبيني والله ما فلودش همش تشيليره وبيع الروح يعني surprisingly براستي نبيني like a valve okay انجا 3 way تابع يترمى سهم كاين لسرا استعمل سامي لسر ليره ويتدرو ليرشو يتدرو شتاين ليرشو يعني aspiration filtration aspiration infusion
كمان inlet أمان
أو سهمك ولا شو بيني أتواني inspiration and infusion okay استعمل مثلا كامل لوكا استا هيجي لوجنيا أي استا كامل لوكا
يسمى بوك
ما شاء الله شيء بقول الجامع كامل زاني aspiration طبعا هو كجو فلاش يكي بم شتشتي كان هي تثبيت يكي أما عندي بس رمية باشا بس خاك استوشي نبي أنا تأخذ 12 ساعات you can maintain this up to 12 hours and unless you are going to find the intravenous access okay what is complication infection bleeding or fracture sometimes okay
Pathological fracture later.
yes iatrogenic you can yes it will happen or extravasation sometimes and in the conscious patient this is very painful so how you are going to minimize that by local anesthesia what is the dose maximum dose allowed in adult local anesthesia
local 2.5
it is 3 milligram per kilogram it is the bupivacaine to find 2.5 milligram prilocaine 0.5 milligram lidocaine midazolam is for conscious sedation. This is for local infiltration. We have nerve block, you have conscious sedation, and you have local infiltration. This is local infiltration.
So the local anesthesia that I give, I should reach it to the bone or to just the tissue?
The tissue, and you will hit the periosteum of the bone also. Yes, it is very painful. How you can predict there is local anesthesia toxicity? What you will tell the patient if the patient feel what sign you are going to think about of the local anesthesia toxicity?
Tachycardia?
Perioral
arrhythmia
numbness, metallic taste in the mouth. In that case, you are going to withdraw and shift to the management of the local anesthesia toxicity. Why local anesthesia toxicity is dangerous? Because it led to
arrhythmia
يشكل كان نبي cardiac arrest. Toxicology. Okay, what is the antidote? What should you prepare?
lipid
Emulsion?
Afrin, excellent. Just intralipid, lipid emulsion. The dose is 0.5 mol, 1.5 mol per kg. Concentration is 20%. Concentration lidocaine بش حسابك ايه؟ نا چه خورنا خزانی ما هادو كان برسي ما ناراس كل هرس
Could you speak in English?
ما قلتاك lunch time after 2 minutes you are going to down don't worry it's okay. Now let us review our summary okay what is the indication of the intraosseous
3-field attempt of cannulation.
okay
inaccessible vein
yes what is the names of this cannula what is the name of this metallic cannula easy IO this is well recognized company called Easy IO. The blue one is for pediatric, the pink one is for adolescent and small adult. The yellow one, this is This is verses of the cannula, you know, because the cannula, the yellow one is the 24, which is carry a very small caliber, you know.
Makes
The
sense.
large one is the green or orange or white or black, okay?
This is opposite.
Which convey about 240 in 1 minute. Okay, good. So, summary, how you are going to recognize airway in conscious patient? Airway at risk in conscious patient. Who can tell me? Strider, gurgling, snoring, and by inspection you may see
Unilateral or even
lip
unexpressed.
swelling, tongue swelling, bleeding, neck edema, or any symptoms of the anaphylaxis. In that case, you are going to ask the patient to open his mouth to see for
Any foreign body.
foreign body swelling.
Excretion.
And if the patient can control his airway by spelling, swallowing, now you are going to just satisfy by putting oxygen. Your target of the oxygenation is by pulse oximeter,
94 plus.
unless if the patient got COPD. You are going to use controlled oxygen supply 88 to 92. Now the patient unconscious. You put the patient in supine position, doing maneuvers, head tilt, chin lift, and if you are suspected of the cervical spine, jaw thrust. Now we look into the mouth using what's called suction and basic airway. By putting a suction tube, you can say the gag reflex is
Present or not?
if present, means the patient cannot tolerate oropharyngeal airway. So you are going to use
Nasopharyngeal.
excellent and put oxygen. If the patient got after that, you are satisfied, I'm happy about the breathing, the airway, I'm going to check the breathing.
Yes.
What is the first thing you are going to ask in the breathing? Respiratory rate. And you'll expose to inspect for any deformity, chest elevation, any chemosis, any signs of the obstruction. And by palpation, you'll do palpation, percussion, and auscultation. Okay? Now, respiratory rate is 25. Still, you'll give oxygen. Respiratory rate 40, you'll give oxygen. Now, respiratory rate is 9. What will be in your mind?
Unsatisfactory. That way, ventilator is
Excellent.
failing.
So, you should give oxygen by ambobagging, by ventilation.
Assisted ventilation.
Okay? Good.